Hi, welcome to the first section in your professional practice module. We're going to look at historical perspectives of WOC nursing and do a brief overview of the specialty nurse role. It can be a little confusing as to what we're doing and how we move from being the registered nurse at the bedside or even in a nurse practitioner's role to one of the WOC nursing specialty. Our objectives today will be to understand the historical perspectives of WOC nursing role, as well as identify what the current roles of the WOC nurse might look like in your agency. We're going to correctly utilize the titles for nurses who are specializing in the areas of wound, ostomy, and continence nursing, as well as describe key competencies for the specialty practice nurse. We'll look at identifying specific ways in which specialty nurses can contribute to infection control initiatives throughout their agencies and try to differentiate between specialty practice and the advanced practice nurse role in regards to terms, educational requirements, and the scope of practice as well as options for reimbursement. Where I'd like to start is with a wonderful relationship that actually began in October of 1958. Dr. Rupert Turnbull met Norma Gill Thompson. They are our founding forefathers and foremothers, I guess is what we could call them, for the WOC nurse as we know it today. In 1958, Norma Gill Thompson had received an ileostomy and had actually taken it upon herself to start to help people who had had ostomies to learn how to deal with them and what to do in order to take care of their new bathroom situation. So Dr. Turnbull was the surgeon, and he really enjoyed having someone to help rehabilitate his nurses or his patients, and he wound up working at the Cleveland Clinic, and they actually developed the first formal school for interstomal therapy, which is what we used to be called, in 1961. At that point in time, in order to attend the school, you actually either A, had to have a stoma, or B, you had to have a loved one who had a stoma and you were helping to take care of them. In 1968, in I believe it was Las Vegas at the poolside is what they told me recently, the people who had become ETs at that point in time had gotten together and they formulated their first American Association of Interstomal Therapists group and started having annual events and annual meetings so that they could actually share experiences and share what they had learned. In 1969, they changed the name of the AAET to the North American Association of Interstomal Therapists. And in '71, they actually changed the name to International Association of Interstomal Therapists. Now, the IAET actually stayed in effect until the 1990s. But in 1976, the IAET, which we have to remember these were lay people who actually had ostomies or loved ones who had ostomies, actually had enough foresight to realize that the role that they were playing for ostomates was becoming more complex and involved and really needed to be part of the role of a nurse. And at the same time, nursing itself was going through changes and incurring the identity of being a professional and actually moving towards the bachelor's degree programs. And so it became a natural function for an ET to become an ET nurse. So the ET role became a nursing role, and so we were known as ET nurses. In 1979, it became a board certification role, and what you received at that point in time, your credentials were CETN. In 1981, the Canadians actually decided to break away from the IAET and become an association all of their own, and they still today function as a very strong organization, the Canadian Association of Interstomal Therapy. They still call themselves CAET as well. In 1985, the IAET elected to have BSN as a requirement for ET nursing school attendance. And in 1991, we went through a rather tumultuous time in renaming ourselves. We actually became wound, ostomy, and continence nurses at that point in time, and we renamed our organization to the WOC and Society. We felt that it actually better reflected what we do on a day-to-day basis and how our scope of practice really does focus on the individual scopes that we practice of wound care, ostomy care, and continence care. In 1991, the BSN requirement actually was removed, and you could then be an RN with a baccalaureate level degree. You had to have certain competencies at that point in time, but then in, I believe in '92, they dropped that aspect of it, and so nowadays if you have a bachelor's degree and have a registered nurse's license, then you are eligible to start in our program. You also have to have at least 1 year's minimum experience with nursing in order to be eligible for our program, which all of you know, or you wouldn't be here right now. Anyhow, most importantly, the most recent development was that in March of 2010, we gained ANA recognition as a nursing specialty. And so if wound, ostomy, and continence nursing is recognized by the ANA as a tri-specialty practice. Our professional organization, your professional organization, which I hope most of you have already joined. If you haven't, it would be really advantageous for you to do it now while you're in our program, because WOCN actually offers you the ability to join at a reduced cost, which is $65 for your first year. If you're already a member, I believe if you want to pay for your next year's membership, you can contact them and get it at the $65 fee. Your WOCN.org is the website, and it's really a wealth of information. There's actually a section that's on here for new members, which is really nice and has a lot of things that you can purchase. There's some education essentials that you can get, and they actually help you to start into your practice initially. So it would be good to peruse this area and look around and see what's going on. The forum is also really good to join. Whenever you look at it, it has, you can list a question and get answers from people all over the world. So it also has a link to the JWCN, which is our research peer-reviewed journal. The journal also comes to you free of charge as a part of your membership whenever you purchase it. So in moving forward and looking at the current roles of the WOC nurse, most people find themselves in the role of the clinician consultant. In this area, you actually work to manage patients who have ostomies and continent diversions, potential or actual skin breakdown, as well as acute and chronic wounds. You also work with people who have fecal and/or urinary incontinence issues. Many of you will find that staff development is a high priority. This really does help you survive your agency and not be the person who gets picked up off the floor every Friday afternoon because of the workload you're actually producing, because there's nobody else to help you. But if you can encourage people to learn more about wound care and ostomy care as well as continence care, that tends to help you with the day-to-day job, and that helps you to be available for those people who are most acute and really need your level of expertise. Also, leader and manager is another role. You lead your own practice as well as that of the practice of the nursing staff. And then research consumer. We actually look at how products are developed. We look at incorporating certain products into our agencies, and in doing so, you're you're doing some mini research studies. If you're trialing products to see if your staff like it, if it will work for your agency, how it impacts the cost factor within your agency, et cetera, et cetera. So moving from there into what's in a name. So this is really a big key thing, and I have uploaded a document that was created in, I guess, the late 1980s or early 90s, I guess it was. Anyhow, Lori McNichol wrote it, and it's a good article for you to read. Prior to certification, once you've finished Emory, if you're a full scope practice, you'll be a wound, ostomy, and continence care nurse. So you can actually put WOC nurse behind your name. So you would sign it BSN, RN, WOC nurse. If you're practicing one of the areas of specialty and doing just wound care or continence care or ostomy care, then you would actually, or even the wound and ostomy care, you would sign as a wound care nurse, ostomy care nurse, continence care nurse, et cetera, et cetera. And yeah, you would need to write all of that out, probably. After you get certified, the initials can be a mouthful, but if you're a full scope of practice, that's actually passing 3 certification exams, because each exam is given individually. So you will be technically a certified wound care nurse, a continence care nurse, and ostomy care nurse, which would give you the full credential of CWOCN. And then if you're practicing as a wound and ostomy care nurse, they have accepted now or registered the credential of CWON, so that you don't have to write out CWCN, COCN. But if you are doing wound care and getting certified in wound care and getting continence care certification, then you would actually sign initials of CWCN, CCCN, just to let you know. Oh, sorry, I forgot I highlighted those. And then the other credentials or initials that you could possibly acquire would be CFCN, that's for foot and nail care, that's a certified foot and nail care nurse. And starting of January 2015, you have to have a bachelor's degree in order to sit for that exam. And then in August of 2015, no, June, I think, I'm sorry, I take that back, May of 2015, they are making this a pathway for certification for foot and nail, a requirement to have 25 continuing education credits, as well as 40 observed or precepted clinical hours for the exam. So if you're an advanced practice nurse and you sit for the advanced practice certification exam, you would have the same initials as the previous initials of certification, except you would have hyphen APs located behind it. Sorry. So, the essential competencies of a specialty nurse and why ANA was able to recognize us as a tri-specialty practice is because we actually have legally sound and ethical practice. We adhere to standards of care and regulatory guidelines as established by our society. You can purchase those online as well as through the WOCN, and as a member you get a discount to purchase those. Our focus in clinical care is definitely patient-centered, and we have clear and comprehensive documentation when we are seeing our patients. We have the ability to offer clear communication to our peers as well as to other professional caregivers, and we are recognized because of our ethical background and ethical issues in our stance with regards to those. We are adept in pain assessment and management, some of us better than others, but we actually know how to utilize our resources in order to take and help our patients manage their pain in a more effective manner. And then we also maintain our licensure certification as well as insurance. Some of you may not have personal liability insurance, and that's a choice, but most all of us will carry professional insurance, and your agencies tend to carry the professional insurance. The certifications that you get when you sit for our certification exam, your initial certification has to be done by a test. After you've done the initial certification, you will need to recertify in every 5 years. But during that 5-year period of time, you can keep account of your professional growth and earn PGP points. And whenever you earn those, you can upload those points and be certified through that route. And then definitely maintaining your current licensure. The other competencies that we hold as a specialty nurse is strong critical thinking skills, which we have actually assessed that while you were here during your bridge week. You are able to conduct comprehensive assessments, synthesize the data, recognize what needs your patients have, as well as your clinicians that will be working with you, and identify the appropriate consults. You're committed to evidence-based practice. We maintain a current knowledge base with regards to our practice. You can find that as evidenced in the guidelines and the scopes of practice, or the current guidelines that are produced for each of the entities that WOCN has available. You also are able to utilize the resources such as our journal or other peer-reviewed research journals. And then also utilizing the resources that you have through us, and then doing literature reviews. We'll look at some of that in the next section. The development of agency-wide programs is also what we're capable of doing. You, as a result of your new role as a WOC nurse, you'll be looking at the policies and procedures for your agency, and looking at staff development, which we spoke about a little bit earlier, as well as the clinical care and consults. Those all will actually be a part of it. As a WOC nurse and specialty nurse, we practice interpersonal competence and collaborative skills. We're able to speak the language as well as hear what others are saying. And then we've actually been able to move into a literacy competent area of digital communication. We practice email etiquette, and with that regard, many of us have actually had to take and rethink our email addresses and use more appropriate ones that are professional, with regards to saying like our first name dot last name at gmail.com or at hotmail.com, instead of some of the other ones that wouldn't be recognized. So if you're actually looking at social media and joining LinkedIn, or even on Facebook and having a professional page on Facebook, it really does help to have just a simple professional email address, so that it's separate from the home address and separate from the home email address. So we also are able to utilize the electronic resources that you would use for doing your lit searches, or even for doing your electronic medical records documentation. The day is gone for not being able to actually utilize and function on a computer. You've had to learn how to take and manipulate Word documents and Blackboard, and how to upload and submit information, as well, or your assignments. And then you've also had to learn how to utilize the computer for emails, as well as scanning documents, et cetera, et cetera. So if you aren't feeling real comfortable in the age of digital communication, do yourself a favor and spend a little money and get some classes, attend some classes, and learn how to use it, because it really is the way we're moving nowadays. Now, I can tell you, I have just recently joined LinkedIn. I am on Facebook for the first time, and I haven't quite gotten the concept of a Twitter account, but I have a friend who keeps asking me to join. So I'm looking at that possibility. I'm not sure how far I will go, but I am trying to learn, even as a 57-year-old. So the other part of being a WOC nurse is actually looking at infection control. We see patients in all facets of health as well as illness, and as a result we may actually encounter different levels of infectious disease. So we'd like to spend just a few minutes looking at that for you. As you know, I like this little diagram. Our hands are a germ farm, and the number one thing that we can do is definitely wash our hands with each of our, before, after, and during seeing our patients. Some general principles to remember with regards to infection control, and part of the reason we're going over this, just to let you know, I'm sure you all know this information, but just to let you know, it's part of what's on your certification, on your final exam. Anyhow, infection control consciousness is what we actually need to be mindful of. We can transfer germs from patient to patient or from us to someone else. Infections, as we know, delay healing as well as increase mortality and can increase length of stay and decrease the ability of agencies to actually get payment. CMS has actually determined that they will not pay for nosocomial infections. They're considered medical errors. So that's why there's a big push, and we know that there's the patient safety is focused on catheter-acquired UTIs as well as ventilator-acquired respiratory illnesses. So the number one tool, as we mentioned, is hand washing. It's essential if you are in between patients, but the CDC guidelines currently state that you can use an alcohol-based sanitizer to cleanse your hands up to a maximum of 7 times before you have to actually wash with soap and water. After that 7 times, though, you must wash with soap and water. Then you can start to repeat that alcohol cleansing up to 7 times again. Unless you actually see soiling on your hands, or unless you are in the presence of someone who has C. diff infection. C. diff is not cleansed with an alcohol-based sanitizer, so if you are taking care of someone who has C. diff, hand washing is a must. The other principles to be mindful of is caseload management. We definitely want to see our immunosuppressed patients first. Then you can follow that by your clean patients, and then looking at your infected patients last. However, you know, when you get to work, it's not the person who's your immunosuppressed patient who tends to have the issue whenever you first get to work and they call you stat. The infected patient tends to be in that realm and category. So as a result, if you must see the infected patient first, then what you want to do is take double precautions or extra precautions when seeing your immunocompromised patients. You could double gown and glove with your infected patient, as well as making sure that you double gown and glove when you go to see your immunosuppressed patient. The other thing to be mindful of with regards to infection control is to remember that our instruments are definitely an extension of our hands. Just as we wash our hands between patients, if you're using your scissors and pulling them out of your pocket, you will want to wash your scissors as well. Many places have gotten to where they do not allow clinicians to carry their own stethoscopes or scissors, and so each patient is given their own in a hospital setting. But just to be mindful of that, if you are using your own scissors, then you will want to take and wash them as well. Clean versus sterile technique, people get confused on this. There is more research that needs to be done. However, our job typically involves clean technique for the most part. Once in a while, you may wind up needing to do sterile procedures, and the considerations to be mindful of with regards to that are that sterile instruments are typically used for debridement. However, it's considered a clean technique. So you'll want to use sterile scissors and pickups but then you can use just the standard gloves out of the box whenever you're doing the procedure. There's sterile procedure when you're catheterizing the stoma for an ileal conduit urine specimen, just as you would using sterile technique to take put a catheter into someone through their urethra. If you're applying a sterile dressing into a wound that communicates to a sterile body cavity, such as the VADs or ventricular assistive devices that are directly connected to the heart, or someone who may have had a thoracotomy and have a big open chest wound that connects directly to the lung or the heart and organs that are definitely right there next to it. Clean technique is typically used in dressing changes, and you will notice that if you think about it, you'll go through a number of gloves and hand washings. So what you would do in a typical dressing procedure would be to wash your hands, don gloves to remove the dressing, throw the old dressing into the garbage, remove your dirty gloves, wash your hands, put on new gloves, then cleanse the wound bed, throw that away, take off the old gloves, and then wash your hands, don new gloves, and then take and put on the clean dressing that you're going to apply for your patient, and then toss the gloves that you just had on, and then take in, wash your hands again. The other general principles to remember are personal protective equipment. Gloves are mandatory for body fluids and soiled surfaces. Gowns, face masks, and eye protection are definitely required if you're expecting to do procedures that may have spray or splashback. So if you're doing some wound irrigation and the wounds tend to be pretty nasty, as well as you're using a forceful spray bottle for delivering of the wound cleanser, you may actually want to put on the gown and gloves and the shield to take and make sure that you don't get splashed back on you. Your resources with regards to infection control is definitely the WOCN.org. Infectious disease physicians are great allies, as well as your infection control practitioner. In my previous hospital job, I actually covered for the infection control practitioner when she went on vacation, and so it was imperative that I learn a lot more about infection control. The CDC has a wealth of information. Their website is cdc.gov. If you're ever confused about the precautions that are needed, you can actually go to their website and it pulls it right up for you, as well as your county health department tends to be a wealth of resources as well. Now, in looking at specialty practice versus advanced practice roles, the definitions help to give us a clear delineation. Specialty practice nurses are those who have developed expertise, such as you and I, and obtained certification in the area of that specialty practice, i.e. wound care, ostomy care, and/or continence care, and/or even foot and nail care. Advanced practice nurses, on the other hand, are nurses who actually practice beyond what is known as the traditional nursing practice. They are practicing in areas that are traditionally considered medical acts or overlapping areas of practices. There are 5 recognized advanced practice nursing scopes. One is that of nurse practitioners, certified nurse midwives, certified nurse RN anesthetists, and then clinical specialists. Sorry, that's 4. And the clinical nurse specialists are actually master's prepared RNs that meet the requirement of traditional medical acts overlapping practice areas. Specialty practice nurses are not eligible for Medicare reimbursement. Advanced practice nurses who have a provider number are eligible for Medicare reimbursement. So if your highest degree is a bachelor's degree, then you fall into the realm of a specialty practice nurse. And your facility cannot charge or use you to be able to charge for Medicare reimbursement. However, they can do an adjunct to physician visit. So if you're working in an outpatient clinic setting, if you are seeing a patient in conjunction with a physician, the visit may be a longer visit, so it can increase the charge in regards to that aspect. However, if you're a master's prepared nurse and you don't have a provider number, much as myself, I have a master's degree. My master's is in public health nursing leadership. I did not seek to do an advanced practice role. So I therefore cannot charge for reimbursement and can't have someone think that I am eligible to be able to charge for Medicare reimbursement. So only if you are a nurse practitioner or a clinical nurse specialist who actually has the license and provider number from your state can you actually bill Medicare for your services. So, and I hope this has helped to clear up the some of the questions that you may have. The thing about our organization, we just finished our 46th annual conference in Nashville, Tennessee, and it was lots of fun, and there was a wealth of information to actually glean. Future conference dates are located on the WOCN website, but I pulled them up here for you. Next year it's going to be in San Antonio, Texas, and then in 2016 we're headed to Montreal. So that will be fun to actually combine with the CAET to have their conference. Just to let you know, and whenever you are trying to maintain your currency of knowledge base, one of the things you can do is attend conferences or attend either the national conference or even your regional conferences. They are always a wealth of information for you. And then also reading your journals is also the other way you would want to take and maintain your current knowledge base. I hope this has helped, and I've left you a couple of resources on the website. One is to give you a history of WOC nursing. That was actually in our brochure, I think a few years back when we had a major celebration. And it just was really a nice timeline. And then the other is to read the article that's A Rose by Any Other Name, and it talks about WOC nursing and how to actually name yourself. I hope you enjoy the rest of the professional practice module.